feel like a thought leader, let me tell you a little something that you should not do if any of you are speakers at conferences or you do television appearances. And I'm always finding new ways to humiliate myself. And this morning, I had to shave before coming to this conference because it's just not done to look scruffy for CannaTech. So, what you don't do is shave in a hurry when you are going to be speaking in public or going on TV. Because what did I do? But I opened up my chin and now I'm bleeding like a stuck pig. Fortunately, all was not lost because long ago a friend of mine taught me a little trick, and that is, if you have eye drops, this is exactly the same substance that's used by cornermen for boxers to close cuts over the eye. So all was not lost, everything was saved, and I'm not standing before you with a river of red running down my face. Now, the topic that I'm speaking on today, I think the formal title is Investing in Compassion, Guiding Patient Access. And this happens to be something that I feel very passionately about. And it's something that I want to suggest all of you who are involved in the cannabis industry need to take seriously, because we all know we're inventing a new industry on a global basis. And I submit to you that we all have a duty, a responsibility for advocacy. That means looking out for patients in a number of ways. We are the ones who have the knowledge. We are the ones who have the passion. It's our job to lead advocacy, to partner up with like-minded organizations, patient groups, and activists, and work the advocacy angle to achieve certain things for medical cannabis patients around the world. The things that we're looking for are, among other things, to ensure that medical cannabis systems are set up correctly from the beginning. That's not something that we should take for granted. There is a medical cannabis system in South Africa now. Does anybody know roughly how many patients are registered to receive? 56, I hear. Anybody know how many in the United Kingdom, which has, theoretically, a medical cannabis system? Anybody know? In the back there? Yeah, a few dozen at most. Okay, so obviously the job is not done in terms of patient access. But what we need to do right from the beginning is look at the architecture of medical cannabis systems. And I argue everywhere I go in the world that medical cannabis systems need to be set up, first of all, well-regulated. Not loosey-goosey, well-regulated, with inspectors. Why is this important? Because patients deserve to know that their product is safe. And we don't, in most countries, allow people to have unregulated meat or milk, nor should we let them have access, if they are patients, or force them to access unregulated cannabis. And until regulated cannabis systems are put together, people are dependent by necessity on the black market. In some cases, black market producers are conscientious, and they think about that end user, the patient, and they protect them. In other cases, we simply don't know because there's no regulator looking over the shoulder of an illegal producer. And so what regulation should do is ensure that the cannabis products, whether it be flower or derivatives, is safe for patients. And this can be profoundly important for certain patients. Think of those who are immunocompromised, people suffering from HIV/AIDS and undergoing treatment, people who are undergoing cancer chemotherapy. Those who are immunocompromised cannot afford to have tainted cannabis products. And they can be tainted, as you know, in multiple ways. Microbial contamination, heavy metals, pesticides that are dangerous. In Canada and in the US, some producers have gotten caught using myclobutanol to fight powdery mildew. Does anybody know what happens to myclobutanol when it is combusted? What does it turn into? Anybody? Hydrogen cyanide, thank you very much. So, regulation matters. We have to ensure that patients have access to quality product. We have to take this seriously. But regulation alone is not enough. We have to worry about access. Access. And around the world, medical cannabis systems are being established without a good, solid, long-term vision or strategy. My sense is that's the case in South Africa, along with a lot of other countries. And it's not because people are necessarily being malicious. It's just that these things are being put together, these medical systems are being put together, in most cases, on an ad hoc basis. As a Canadian, I understand that. That was the Canadian experience. It was the Supreme Court of Canada that ordered the then Conservative government 6 or 7 years ago to create a truly accessible medical cannabis system. One of the things that we can take pride in, and I'm not joking, in Canada, is really good bureaucrats. Really good bureaucrats. Our public servants at Health Canada, I'm very proud of them, because in a very big hurry, they put together a really good set of regulations, an excellent framework. And then they had to update it to allow for cannabis oils and other derivative products. They've worked fast, they've worked well, they've acknowledged that they may not get it all right the first time. And if you want an example, a couple of years ago when Health Canada created regulations to allow for cannabis oils, they also created regulations to allow for fresh cannabis. Now, I don't know who ever has purchased fresh cannabis, and you wouldn't even want to ship fresh cannabis in Canada's system, because I don't want to have anybody send me fresh cannabis and guess that there's not going to be any mold on it by the time I receive it. So it's kind of a legacy of regulation in a hurry. But to their credit, the Health Canada bureaucrats work closely with the industry, and they have been prepared to evolve the regulations as they go. It's not perfect yet, but it has created a good model for other countries. So access should include making sure that there are not roadblocks to patients receiving their medicine. Why are there only a few dozen patients in South Africa's and the UK's systems? Because of those roadblocks, put up intentionally or unintentionally and left there, and they need to be dealt with. In Australia, they had a very similar problem until about a year ago. 2 years into their medical system, they had 1,000 patients in it. And that's not the total number of people who wanted access to medical cannabis, who needed access to medical cannabis, who needed an alternative to opioids, to benzodiazepines, to sleep drugs, who needed help with their bowel disease symptoms, or their anxiety, or their epilepsy. The demand was there. But initially, it was bumpy and awkward, and too many roadblocks existed to patient access, among other things. There was a dual system of registration. You had to register at the federal level and at the state level, and the delays could be months if you got approved. There was an initial list of approved indications, and it differed from state to state. In one state, there might be 4 approved indications, say cancer, epilepsy, or a couple of other things. In another state, it might be different indications. And by the way, one thing that public servants, I don't think, should be determining is who is an appropriate patient for medical cannabis. That's a discussion that needs to happen between a patient and his or her physician. They changed that. They changed the dual registration system and made it a single online process. So what could take months before, now can take as little as 2 hours. And something else, critical, and I hope the UK is listening. They removed the requirement that it be a specialist physician that write a script for cannabis, and they opened it up to general practitioners. This is critical. General practitioners with proper continuing medical education, or I think in South Africa they call it continuing professional development, CPD. General practitioners are more than capable of prescribing medical cannabis, and I'll tell you something else. If the Canadian experience is any guide, they are appreciative of the availability of this tool. I'll tell you a quick story. In the little town close to where I live, in the countryside outside Toronto, is our family physician. He's a guy about my age. I have coached his daughter's soccer team on a number of occasions for different years. And he's not what you would call, in the pharmaceutical parlance, an early adopter. He's not somebody who tries radical things or wants to be first. But I was talking to him a couple of years ago, and he said, "So, Cam, what are you doing?" And I said, "Well, I'm helping run a medical cannabis company." He goes, "No kidding, I've got 12 patients on medical cannabis." Perfectly ordinary small town general practitioner in Canada. And how it happened for him, I've subsequently confirmed with other physicians in Canada and in other countries now. It looked like this. He decided to try it for somebody who was undergoing chronic pain and had had a previous dependency problem with opioids. That's a story we've heard a lot around the world. And he got good results. So having done that, he next tried it on a patient with a sleep disorder. And it worked for her as well. And then he tried it for other indications. And it became a go-to tool for him for a broad number of conditions. And one of the things that made it so accessible, a good tool for a physician to reach for, is something that we all know about cannabis that makes it very, very special. What is the level of lethal overdose for cannabis? Come on, tell me. Right, there is none. There is none. You can't die from cannabis. Holy cow. That is so rare. You can't say that about aspirin or paracetamol, acetaminophen, Tylenol. It's a very rare substance in medicine that is that foundationally safe. And so physicians like it. So give the physicians the tools, open up these systems, ensure patient access. But we have to go farther than that. Cost is a problem as well. Cannabis is not the most expensive thing in the world as a consumer product, but if you have to take it every day to manage your symptoms, particularly those who require higher doses, it is not inexpensive. So, in Canada, companies like Aurora and others, we have what we call compassionate pricing. So, in Canada, for any patient who makes under $30,000 a year or is on federal or provincial disability, they pay 30% less for their cannabis. We do other things out of this sense of responsibility for these patients. We're a business and we have to make money, but we have to think about those patients. They matter. Their lives matter. Think about the experience that they're going through. They are already dealing with a chronic illness. They've tried a whole host of other medical treatments before they turn to medical cannabis, in most cases. They turn to medical cannabis, and the cost is a struggle. And what has the government done in Canada and elsewhere? Layered taxes on top of it. In Canada, cannabis is the only prescription medicine for which any tax applies, and we certainly apply it. We apply what we call the GST, HST. It's a value-added tax. We apply an excise tax on top of that, and that excise tax is exactly the same. The taxation of medical cannabis for patients with chronic illnesses is exactly the same as the taxation of cannabis used by adult consumers. Is that fair? Does that make any sense? Are we achieving any good? So one of the things that we do at Aurora is we eat the tax, the excise tax, for medical patients. Not for adult consumers, but for medical patients. We eat that tax, and it amounts to millions of dollars every quarter. But it's part of what you need to do to be a compassionate company, and we need compassionate companies in this business. We need advocacy to be at the core of what we do, because if we don't do it, who will? There is not yet, with the short duration of this industry, a long-standing experience with patient advocacy. In some countries, there are still no patient advocacy groups for medical cannabis patients. It's our job to set aside a bit of our time and a bit of our hearts, all of us who are involved in the cannabis business in every part of the world, to advocate with governments, with insurers, whether they be public or private, to start to do the right thing, to treat cannabis as an ordinary medicine, to think about the lives of those people with chronic illnesses who disproportionately use medical cannabis. People are not using medical cannabis because of an acute headache. They're using it because they have a chronic condition, and they need our support. So if you want to consider this a call to action, then that's fine. That's exactly what it is. We all have a responsibility to stand up for the patients. And it has to happen now. By recent count, there are now more than 40 countries in the world that either have a medical cannabis system or are putting one in place. But we cannot leave this to the policymakers and the regulators. We should educate them. We should meet with them, tell them about the prior experience in other countries that have more experience, that have a longer period of time with a working medical system, and have shaken out some of the bugs. Let's try and help governments to get it right the first time. And if they don't get it right the first time, then we stay on them. And we continue to advocate for evolution in the regulations so that we have well-regulated medical cannabis systems that serve patients well and protect them. And so that patients have truly good access, which is what they deserve. Now we're all very busy people. We're business people. We have things to do. We have companies to run. We're all striving for profitability. Great. But we owe it to the people who made our industry possible, along with the activists and the advocates who were so right for so long and have pushed successfully country by country to make these things happen. The patients have to be at the front of our minds, and we have a duty to them. And that's about all I want to talk to you about today, and I hope you will take some of this sense of mission home with you, and will act on it and do the right thing. And I'd be happy to take a couple questions if you'd like. Thank you so much. This gentleman waving, hi.
I don't know if you can hear me.
Here, let me come to you.
Okay. Great presentation. Couldn't agree more with everything. One of the things, I come from the pharma industry. And the pharma industry has the FDA and adverse event reporting, and we've been doing that for years. One of the things I think is lacking in the cannabis industry, that I love the way you talk about good bureaucrats, is it the responsibility of the government and the bureaucrats to create an adverse, because there are adverse events that we need to know about, whether it be tainted product or cyclic vomiting, or there are known AEs that as an industry we want to collect as well as by product that we want to collect from a public health perspective. Should that be responsibility of industry, or should we look to the bureaucrats to help us with that?
So in Canada, Health Canada does capture adverse event reports because it's a nationally regulated system. The FDA, let's be honest with you, the FDA is going to end up regulating cannabis. It's going to happen. They regulate not just prescription medicines, they also regulate tobacco now. They are going to end up with national regulations. And I think we have to accept that that's a good thing. There will be those in the industry in the US who will be opposed to it. They'll actually, in some cases, for very good reasons. The level of regulation in some states is, by Canadian standards, unacceptable. Unacceptable. In some states, it's actually very good. When it is regulated nationally, patients will be better protected and consumers will be better protected. And we've got to maintain those two systems. So my feeling is that something akin to a Canadian system where you have a separate but parallel regulatory system for medical cannabis beside prescription drugs that does capture adverse events is absolutely critical. And you're right, we do need to track this. We don't even know what the incidence of cannabis hyperemesis syndrome is. Does everybody know what that is? For some frequent high users of cannabis, chronic users, they develop a syndrome that is not well understood, known as cannabis hyperemesis syndrome, where people just have intense vomiting. It won't stop. And they try things on an acute basis, like getting into a hot bath or shower, and that seems to calm it down. But the only known cure thus far for it is to stop using cannabis, period. It's believed to be quite rare, but we don't know. We don't know how common it is, and we don't know what level of use over what period of time it causes it. So we've got to track that. And you're right, tainted cannabis. Adverse reactions of all kinds. Any therapeutic substance is going to have risks, benefits, and side effects. We've got to track these. Any other questions? All right, thank you very much for your time, everybody. Enjoy the rest of the conference.
Thank you, Cam, so much.